Evening, everybody. Once again, I'm Yahya Muhammad. I'm going to lead the discussion today on the topic hepatitis. Uh, I'm neurology in training from Aminu Kano Teaching Hospital. You are all welcome to this discussion today. So I believe and hope at the end of the discussion is going to be fruitful. We learn and remind ourselves one or two things that are important for us and for our practice now and exams. Okay, so I'll try to make it as interactive as possible. Again, we also have to be conscious of time. We pay more emphasis on the most important slides. However, all the slides are important. If you have any question, clarification, you can stop me at any time and ask. And I wish everybody will participate actively for this discussion. Thank you. Okay, so we are going to discuss two topics today, one of which is hepatitis, and the other one is chronic liver disease. I hope I'm audible. Am I audible?
Yes, sir, we can hear you, sir.
All right, so let's go ahead. Next slide, please. So these are the headlines. These are the outlines, sorry. Hepatitis, from the word hepatitis means, we all know it could come from various causes, of which the commonest cause are microorganisms. And among the microorganisms, some viruses called hepatitis viruses. These are the most common cause of hepatitis. However, we should bear in our mind that bacteria, parasites, almost all other microorganisms can cause hepatitis. But the most common ones that have more trophism to the liver are viral hepatitis. So again, apart from microorganisms, other substances, chemicals are known to induce hepatitis, okay? So the focus of today's lecture is inflammation of the liver caused by these viruses called hepatitis virus. So it's usually used to describe infections caused by agents whose primary tissue trophism is the liver. And there are most of them, they are called hepatotrophic viruses. They are grouped into A, B, C, D, E, and G. There are recent ones that are yet to be discovered. Okay, next slide. So this, for better understanding of these viruses, they are better to be classified. And their classification can be based on transmission. It could be based on the family in which these viruses belong. And again, it could be based on mode of transmission of these viruses. Okay, so we said based on transmission, there are those that are transmitted via enterically, meaning has to do with gastrointestinal system from the maybe fecal-oral or some other form of enteric transmission. And if you can see, there are classically A and E, and then there are those that are transmitted via blood and blood products parenterally, and they are B, C, D, and G. Next slide. So again, some of these viruses has 4 phases of which they cause infection, or let me say stages. And the first is incubation period. Then there are prodromal period, icteric period, and convalescence phase. We come to know the first 2 periods. They're usually non-specific. Patient present with non-specific symptoms that may not even make the clinician to think of hepatitis. And the commonest problem in this environment, many patients have been treated for malaria, typhoid, if they are in incubation or prodromal phase, because the commonest features at that stage are malaria, fever, and feeling of unwell, some joint pains like that, which in this environment, many people think this likely to be malaria. So if you treat a patient without symptom, we have to explore, we have to check other things. But most of the patients at the icteric phase and convalescence phase, The clinician used to think of possibility of hepatitis because they develop some overt symptoms like jaundice and other features of hepatitis. Okay, let's go to the next slide. So starting with hepatitis A, we said, if you remember, we said these viruses, they can be grouped into, they can be classified into several ways, just to have a better understanding of them. We said due to mode of transmission. Will be based on whether they have either their DNA viruses or RNA viruses. Could also be due to the family they belong. Interestingly, most of them belong to almost different types of families. There are a lot of bigger families of viruses. So some of them from Hepadna-Viridae, some of them from Picona-Viridae, some of them from the Callici-Viridae family. There are all sorts of families at which they can be classified. And again, majority of them, they can be RNA or DNA viruses. As you know, viruses exist either in the form of DNA or RNA. Okay, notable for DNA that exists as DNA is hepatitis B. So hepatitis A belongs to a group of viruses called Picona. The family is from Picona-Viridae. Is a small non-envelope, and most of them, they are engulfed in a certain casket, like they are covered. So for this one is non-envelope, it's not envelope. And it's about 27 nanometer in diameter, containing RNA. So hepatitis A is an RNA virus, okay? Move to the next slide. So epidemiology is one of the commonest viruses around, but luckily enough, it doesn't cause a serious disease. It could occur in epidemic or sporadic, and is distributed worldwide, especially in low socioeconomic countries like our own country, Africa, Southeastern Asia, where hygiene is not optimal like in the Western world. And we remember that it's one of the enterically transmitted viruses, okay? So the incidence in the first world countries is declining. There is high incidence in developing countries like Nigeria and rural areas. Okay, next slide. So we have already said is an enterically transmitted, mostly via contamination of food or water with sewage, especially from the infected food handlers. Okay. Large number of viral particles are excreted in stool before the onset of symptoms. Being it enterical, we expect the virus from the fecal-oral gets to the mouth, to the GI, and to the anus. But luckily enough, as I said, it does not cause significant. Majority of the symptoms are non-specific fever, wet loss, maybe jaundice, but it subsided within a particular period of time. It doesn't cause significant disease. Next slide. So is an enterically transmitted virus. We expect the virus to enter into body via GI, via guts, and it replicates in alimentary canal and spread to infect the liver, where it multiplies into hepatocytes. As I said, it resolved within a short period of time. That's why the viremia, presence of the virus in the blood, is very transient, and it's excreted in stool in high amount. Okay, next slide. So the virus cannot be called, it's not a virus that you can say you easily cultured. But you have to do presence of hepatitis A virus antibody, specifically IgM. So it's an antibody test that you do that give a high yield of detecting this virus. Next slide. So how do we prevent ourselves from, there is no particular treatment for hepatitis B as most of the viruses. However, some few of B, C, and other viruses, there are specific viral agents that are used for the treatment. So our prevention, as we said, could be prevented by passive immunity and active immunization. And that's why in some of these guidelines for pediatric immunization, some of these vaccines are incorporated into their guidelines. So as all the immunization could be passive or active, passive meaning a preformed antibody is formed somewhere and get into somebody, like, okay, the immunoglobulin that we inject ourselves with, they're usually a passive immunity because it's not our body that produces them. They are produced outside and also taken injected into our body. However, the best form of immunization is usually an active immunization, and that involves injecting a weakened form of the virus in the body stimulating the body's immune response to produce specific antibodies against that antigen of the virus. Okay, that will give us that will give an active immunity that lasts for a very longer time. But the passive ones may not last for a very long time. And that's why most of the passive immunization, you may need to take, even there's some active, you may need to take some booster doses, even for the active immunization, okay? Because it wanes after a period of time. And again, another way that we prevent these viruses is improve sanitation. We said it's fecal-oral, enterically transmitted. So by making our environment, washing our hands, taking care of our hygiene, anal hygiene, and other things like that. So all those can prevent us from contacting the virus. Next slide. So then another one, hepatitis E. So we are going for enterically transmitted. We said A and E, they are commonly enterically transmitted. So E is recently identified cause of enterically transmitted. Before, the name of E is not E, it's non-A, non-B hepatitis. But further studies, after further study, the knowledge and characteristic of the virus was known, and that was why it was named hepatitis E. But before the full research on the virus, it was given a name of non-A, non-B. So it also belonged to Calliciviridae family. You know, we remember that we said hepatitis A belonged to Picona, the famous Picona viridae family, but this one belongs to Calliciviridae. It's a very good family of the viruses, okay? And this can come in your exams. Which of the following viruses belong to Calliciviridae? We should know the other members of Picona, Callici, Hepatna. They are a very active group of viruses, okay? Yes. So the diameter is about 2734, almost slightly bigger than hepatitis A. And it's also an RNA virus, okay? RNA virus. We said most of the viruses are RNA, however, there are a few ones that are DNA. Notably, hepatitis B virus is a DNA virus. Next slide. So how do we diagnose hepatitis E? We don't have some specific lab tests that we do, and we cannot culture the virus. However, we can do serology to detect the presence of antigen in the blood, IgM, particularly the IgM, okay? We can also use polymerase chain reaction to detect sequences of the virus, okay? Again, using electron microscopy, we can see some particles of the virus because we said it belongs to Callici. So we see some particles looking like Callici virus-like particles. Callici viruses have particular shape that can be identified by using electron microscope. So seeing this kind of infection with some symptoms, you can suggest. And again, I want to tell us that these viruses, again, like hepatitis A, does not cause significant disease. But the only situation where it causes a very, very significant disease is in pregnant women. So please don't joke with a hepatitis E virus in pregnant women. In fact, it can cause a fulminant hepatitis. It can cause chronic liver disease in a pregnant woman. It's a very virus that is notorious to infect and cause a very serious disease in pregnancy. So these are kind of virus, one of the screening that we'll be doing to the pregnant woman for these viruses, okay? Yeah. But outside pregnancy, it tends to be very weakened and slow in its pathogenesis. It doesn't cause significant disease outside pregnancy. Next slide. So then the famous hepatitis B. Hepatitis B, we said, is a DNA virus. And before, they used to call it a Dane particle. This is an MCQ question. Previous name for hepatitis B is called Dane particle. And it belonged to famous Hepatna viridae family. There are a lot of viruses belong to this very important viruses. And hepatitis B is inclusive. So belongs to Hepatna, unlike hepatitis E that belongs to Callici, and unlike hepatitis A that belongs to Picona viridae. So this one belongs to Hepatna viridae family and also called Dane particle. And again, if you look, it's a bit larger than hepatitis E and A because hepatitis A is around 27 nanometer, and B is about 27 to 40 to 30 something, and this one is 42. So it's a bit bigger than both hepatitis E and hepatitis A. Next slide. And I want to tell you, hepatitis B and C cause significant disease in every person, both immunocompromised and immunocompetent. There are two viruses that progress to chronic hepatitis as well as chronic liver disease. And they can also even cause hepatocellular carcinoma. So the two of them. So again, it has some antigens in the body called hepatitis B surface antigen, one of the earliest things to appear in an infection. You understand? Again, however, sometimes the body produces antibody against this hepatitis B surface antigen. So meaning it has three antigens, B surface antigen. So the body will produce antibody against this B surface antigen called hepatitis B surface antibody. Then it has co-antigen. But again, we don't detect this co-antigen in the blood. These are unless if you do biopsy. If you do biopsy, yes, we can detect it, but we can't detect it in the blood. So the body may produce antibody against this co-antigen called hepatitis B co-antibody, which can be detected from the blood. And again, they are of two types, IgM and IgG. IgM is seen more in acute infection. IgG is seen more in chronic infection. Then there is another E antigen, which can also be detected from the blood, and as well, the body produces antibody against that, which is called hepatitis B E antibody. So I want to ask, please, who knows which one of them is a marker of replication of the virus? Please, quickly, anybody? Which is a marker of replication of the virus? Please help us, please. Dr. Ben. Hello? Which one is a marker? Is a question for your exams. Which one is a marker of replication? Okay, let me go ahead. People doesn't like to contribute. Hepatitis. Huh? Hello? Okay, hepatitis B E antigen positivity is a marker of replication. So if you have a patient that has E antigen positive, E antibody negative, that patient has high chance of transmitting the virus, and the virus is actively replicated. Okay, next slide. So epidemiology of hepatitis B, there is high prevalence of the disease in Africa. Worldwide, there are 450 million people carrying hepatitis B. The carriage rates vary markedly in the following areas. Hepatitis B is transmitted parentally. So one of the commonest way of transmission of this virus is, we said it's not the one that is transmitted enterically. It's A and E that is predominantly enterical. This one is more parental, okay? But apart from parental, it was shown that even sexual intercourse to some extent, and some association, even the saliva, okay? So for the blood, either from transfusion, sharing of needles, tattooing, and other procedures that involve shedding of blood, okay? So they are known to be transmitter of this disease. Next slide. Next slides, please. So again, for renal dialysis, dialysis involves a lot of circulating blood from one place to another, like that. So sexual intercourse, then even horizontal transmission, maybe childhood plays and other things, contact with some individuals like that, close personnel and other things like that, like children at school and other things, which they share so many things. They share their spoons, they everything together. Vertical transmission from the mother to the baby. This could occur during delivery, either when before delivery, transplacentrally, or even during labor. It could also be, some people are querying even after delivery, postnatal, bare breastfeeding, but there is not much data, there is not much study to back this. Next slide. But the commonest one are usually blood. For both B and C, commonest is blood. But however, there are some sexual transmission also one of the ways for transmitting these viruses. Infection is parentally transmitted, as we said. The virus replicated in the liver, yes. Viral particle as well as the excess surface viral protein are shared in large amounts in blood. But this one, unlike hepatitis A, the viremia is prolonged, unlike hepatitis A that has a transient viremia. So this is one of the virus. That's why the virus can undergo chronicity. Among the hepatotropic viruses, only B and C, and maybe to some extent E in pregnancy, that can lead to chronic stage. All of them, they die off at an acute stage, okay? So the viremia for hepatitis B is prolonged. So that must make it to have a chronic infection. Next slide. Next slide. As I said, both B and C, again, they're the one involved in chronic. And as I said again, A and E, they don't commonly have particular specific. Most of the viruses do not have specific treatment. But B and C have particular drugs that are known to cure the disease. So the diagnosis is by serology, as we mentioned, looking for those antigen and antibodies of the virus doing combo tests. You may need to do ultrasound to look for the architecture of the liver and possible complication of the disease, maybe chronic stage or some other, or even chronic liver disease. You may need to do liver function tests, which could be the range in acute stage. So in acute infection with resolution, you can use viral antigens. Hepatitis B surface antigen, presence of it indicates viral replication in the liver, yes. But the one that a marker of actual replication is E antigen. So this one we can say presence of infection in the liver. E antigen indicate high level of viral replication. Co-antigen, we don't detect co-antigen from the blood. As I said, you have to do liver biopsy, but you can detect co-antibody. Next slide, in the blood. So these are the surface, this is the antibody against hepatitis B surface antigen. It becomes detected late in convalescence and indicates immunity following infection. Then the E antigen has its own antibody, which is which serves to protect from the lethal activity of E antigen. That's why E antigen positivity is a negative, is indicative of the virus is actually replicating. And in some cases, it warrants for considering of treatment. Next stage, next slide. Okay, we've mentioned this one. Next slide. So this is the cause of hepatitis. You can see hepatitis B surface antigen, subsequently it went up. You can see again, if it went up, can't see clearly. So you can see the graph. After weeks of infection, earlier you can see hepatitis B surface antigen up to this level. Then hepatitis B surface antibody again, they overlap at a particular time around 12 weeks. Both of them are high, but B surface antigen will become normal at 24 weeks, near normal level, and even B surface antibody again at 32 weeks. So they usually overlap at certain stage. Next slide. So what are the complications of hepatitis? There are a lot of complications for viral hepatitis. One, they can lead to chronic stage, especially B and C, and they can sometimes present in a fulminant pattern called fulminant hepatitis. But this is only seen in hepatitis B and C, and to some extent hepatitis E in pregnant women. Then they could have a persistent infection, which could be chronic active or chronic persistent. Then in some few cases, they can lead to hepatocellular carcinoma. Okay, so liver cancer can develop from hepatitis B and C. Next slide. But these are liver complications. We should remember that hepatitis B can cause other diseases apart from the liver disease. So these are the liver. We know that it can cause glomerulonephritis leading to renal failure. They can cause other infections in the body. Okay, they can suppress the bone marrow. So prevention could be active and passive, which we said. We have discussed about what an active and passive is. And that's why it's incorporated in our national guidelines for immunization. Commonly in Nigeria, we use method of 0, 4, and 4. At 0 at 4 weeks and at 0, 4, and 6. At 0, at day 0, at week 4 and week 6 again. But there are other regimens adopted by different countries. And it's estimated that after 4 to 5 years, the immunity developed produced by the body against the vaccine should wear down. So it's advocated after every 5 years, we should take a booster dose of this vaccine. However, in other countries that can actually measure the level of those antibody in the body, they measure first until when they find out that the antibodies for the virus have become very low, and that's why when they get the booster. But for us, that we don't have facilities for regular measuring of those level of the antibody, so it's advocated after every 5 years or more, we should take a booster doses of this vaccine. So let's go to another one. There is also an RNA virus that belongs to a very important family called Flaviviridae family. So this one is not belong to Callice. It's not belonging to Hepadna. It's not belonging to Picona. It's belonging to Flaviviridae family. And it's an RNA virus. So far we've mentioned almost 3 RNA viruses, A, E, and C, while we only mentioned only one DNA virus. This is very important for the exam, for the MCs, okay? So the following viruses are RNA viruses. Hepatitis C, true. Hepatitis A, true. Hepatitis E, true. Hepatitis B is false, okay? So they can also ask you other families of these viruses like Flaviviridae family and other things like that. So this is an envelope virus, okay? And the most important mode of transmission is parenteral. There are very few or rare documentation of transmission of hepatitis C apart from blood, unlike hepatitis B, where sexual intercourse and other things like that. All right, next slide. Diagnosis, again, it does not grow in culture, so we don't need to do culture for that, but you can do serology to detect the antibody, IgG, in that manner of the virus, okay? So we can use PCR, we can use other form of antigen detection, antibody detection for those viruses, but polymerase chain reaction is one of the methods we use. Next slide. Next slide. Before we move to hepatitis D virus, we should know, as I said, hepatitis B and C lead to chronic stage. Hepatitis B and C, they're the one that cause chronic liver disease. Hepatitis B and C, they are one of the hepatotropic, but they have drug for the treatment. So it's wise to know drugs that are used for the treatment of them. Who can tell us 1, 2, 3 drugs used for treatment of hepatitis B? It's very important for exams and for us to know. Anybody? Hello? Hello? All right, let me speak to myself. Am I being heard?
Yes, sir.
Okay, any drug that you know for the treatment of hepatitis B? Okay. One, interferon. Interferon can be used for the treatment of hepatitis B. Lamivudine is also a very good drug, but it has so many side effects. It's contraindicated in pregnancy and other things like that. So, adefovir is also one of the very good drugs used for treatment of hepatitis B. Tenofovir is one of the commonly used available drug now for the treatment of hepatitis B, and another drug called entecavir. So these are some of the drugs that are used for the treatment of hepatitis B. There are a few other ones. For hepatitis C, there are various groups. They are divided into NS5A, NS4, NS4B, and what have you. So there's many. So sofosbuvir, ledipasvir, boceprevir, and whatever. There are a lot of drugs, but again, they are divided into several. I advise you to go and read about so many of these drugs and their classes, okay? So hepatitis D delta is a defective virus which requires hepatitis B. So it does not on its own cause disease. It requires presence of hepatitis B to help it to proliferate and cause a disease. Infection therefore only occur in patients who are already infected with hepatitis B. It's a viral particle of 36 nanometer. So it's a bit, it's not that big, but it's bigger than A and B. It is encapsulated. So it's also an enveloped virus. It's also an RNA. So far we only mentioned one DNA virus, hepatitis B. All other viruses we mentioned, they are RNA viruses. Next slide. Next slide. Another virus called hepatitis G, originally cloned from serum of sojourn with a non-A, non-B, non-C virus called hepatitis G. It was implicated as a cause of parentally transmitted hepatitis, but it's no longer believed to be a major agent. Okay, as we said, only B and C, they are known. And to some extent, E in a pregnant woman, they are known to cause significant liver disease. It has been classified as a member of Flaviviridae family. Okay, so far we have two members of Flaviviridae family from the one we mentioned. Okay, next slide. All right, thank you very much for the end of first lecture for today. We move to the next lecture, which is chronic liver disease. If there is any question, clarification, subtraction, addition, we can have 1 or 2 minutes to do that. In the absence of that, we can move to the next lecture.
Good evening, sir.
Good evening.
Sir, I have a question.
Okay, what's that your question? I hope I know the answer for your question.
Sir, please, could you explain more what is fulminant hepatitis?
All right, so fulminant hepatitis means somebody coming with form of hepatitis that warrant admission that somebody is looking very toxic. Example, somebody come with features of hepatitis, let's say he started having jaundice fever, but within the next 48, 72 hours, become very febrile, very weak, maybe with some abdominal pain, with some features of hepatitis, understand? Meaning the virus has infected various organs in the body, brain, liver, even kidney, you understand? So patients come, usually they are very toxic and most of them die. So if you have the most severe form of the disease at a glance, within 1, 2, 3 days, somebody will be down with this kind of fever, severely jaundice, abdominal discomfort, and with some features of hepatic encephalopathy. So this is, you can say this, somebody is having a fulminant hepatitis. Unlike the hepatitis that we know that will start gradually today with some fever, weakness for some weeks, days, you don't feel the taste of the food, nausea, vomiting. Maybe after a month or some weeks, somebody will develop jaundice gradually. So you see, that's the normal trend. But for you to within days, within just 2, 3 days, coming down with those symptoms that knock somebody down, somebody is subconscious with some features of hepatic encephalopathy, with fever, with jaundice like that, severe form of the disease. And that is a fulminant hepatitis. And many of them lost their life if they come with that fulminant form of hepatitis. Thank you. I hope I've said something reasonable towards your question. Okay?
Yes, sir. Thank you, sir.
No problem. Any other question, please?
Yes, sir. I have a question, sir.
Okay, I hope I know the answer for your question.
Okay, sir. Can hepatitis B be cured permanently?
Good question. Okay, I'm not a gastroenterologist, but both on what I know and what my teachers and what I interacted with so many professors of gastroenterologists, the cure rate for hepatitis B is just 60%. Okay, this virus is hepatitis B is less aggressive than hepatitis C. But even if you use the most important, the most common drug, only 60 to let's say 80% of the patient with hepatitis get cured. Even if you use the most appropriate, the most potent agent, only what? 60 maybe to 70, 80% cured. But it's have a benign cost relative to hepatitis C. However, for hepatitis C, one can get cured 100%, but it's very aggressive. Within days, it can knock the liver down. But again, if you're lucky, you detect it early, you start the appropriate agent, you can get 100% cured. The reason why is, okay, in advanced countries, they do biopsy and find out from the biopsy, there are a lot of drugs, as I mentioned, NS5, NS4, and even NS5 that went to AB, soposbuvir, ledipasvir, boceprevir. There are all those vir family. So if they do biopsy and some sequencing, they will be able to know which of these drugs that your body will respond better. So if you are placed on those drugs, the cure rate from so many studies can reach up to 95 to 100%. You understand? So it actually can get cured. But however, most of the drugs, you have to take them for more than 6 months, okay? Yeah. Hepatitis B has a very benign cost relative to hepatitis C. It does not just knock the liver in a day, and only 15% of patients infected with hepatitis B come down with chronic viral hepatitis as well as chronic liver disease. About 75 to 80 to 85% of them, they remain asymptomatic. Even if they have symptoms, even if the virus has not cleared, it will remain for more than 1,000 years in their body if they survive to reach those years. So if you have patient with hepatitis B, we just try to check out whether he's qualified for the treatment. As I said, only 10 to 15% that will qualify for treatment. The rest of 75, 85, what they require is monitoring. And the problem we had in this country, if you tell somebody like that, you go back to traditional, or you go back to somebody that is not a doctor, or somebody that is a doctor, but he does not update his knowledge, you understand? So that they start tenofovir. No. There are criteria for commencement of medication. Is beyond the scope of this lecture. So if as I said, more than only 15% or 10% qualifies for treatment, that means those are qualified for treatment. There are those that are potentially going to develop chronic liver disease as well as maybe chronic hepatitis, chronic liver disease, and if possible, hepatocellular carcinoma. So those are the kind of patients that require treatment with those interferon, lamivudine, adefovir, tenofovir, and entecavir. For the rest of 80, 85, all what they need every year, they will do combo liver function abdominal scan plus or minus viral load for monitoring, just to monitor them. If they if they qualify to commence treatment, you commence them. But I believe you me, 75% of them will remain, even if they are going to spend 100 years in their lives with the virus without nothing. And you don't need to give them tenofovir or any other. So cure rate is 60 to 80% if you use the best agent for hepatitis B. But as I said, only 10 to 15% qualifies for treatment. The rest are just for monitoring. So if you have a patient, you have to educate him. You shouldn't go to the village or traditional medication or Shanrake, wherever the traditional thing said. You understand? But again, for some anxious patients, instead of leaving them like that, some gastroenterologists advocated use of an agent, antioxidant called silymarin. Before we use talk of it, we use all sorts of antioxidant, but they have shown not to have any benefit to the patient, only to be wasting their money. But again, if you weigh that, okay, this patient is not educated, he's a kind of person that takes traditional, or that have a tendency to take traditional medication, you can give him something so that he feel that, okay, he come to the doctor and there's a drug he's taking, just for psychological. And that's why some gastroenterologists advocated silymarin. In fact, some people believe that it has some benefit, unlike the tocovir and other antioxidants that we used before, livolene and what have you. Okay, I hope I answered your question.
Yes, sir. Thank you, sir.
All right, thank you very much. Thank you. I'm really happy for answering for asking these two questions, please. Let's have more active participation, okay? So quickly, let's look at chronic liver disease. Chronic liver disease is one of the terminal stage of viral hepatitis. There are a lot of causes of chronic liver disease, but worldwide, the commonest cause is hepatitis B virus, worldwide. However, the commonest cause differs from the location, the environment. Even in Nigeria, in some parts of Nigeria, yes, hepatitis B, but again, there is a rising, alcohol is one of the most common cause. Even if it's not the cause, it's coming closer to hepatitis B in some part of the country where alcohol consumption is very much. And even in other countries that consume alcohol, alcohol is one of the commonest cause of hepatitis. But if you take globally overall, the commonest cause is hepatitis B and C. So chronic liver disease is defined as a clinical or pathological spectrum of liver disease of varying etiology lasting for more than 6 months and characterized by hepatic necrosis, inflammation, with or without fibrosis or neoplastic transformation. Please, this is one of the WHO definition of chronic liver disease, and we should put it in our head, please. Next slide. So this is just a scenario. If somebody come with fever, recurrent intermittent jaundice, recurrent malaise, anorexia, nausea, vomiting, upper abdominal discomfort, weight loss, patient use intravenous. If you hear anytime they told you that one of a scenario in exam, patient is intravenous drug use, one of the commonest infection he can get is hepatitis C. So this, they just want to tell you that about some symptoms of one of the patient, and it's hepatitis C. So now, if they say hepatitis B or C, it's likely to be hepatitis C because of transmission is via blood and is a non-intravenous drug use. So if they mention any intravenous drug use or any procedure that warrants sharing of needles or blood, you think of hepatitis C. Okay, next slide. So this is another scenario, a young perimenopausal woman with amenorrhea, acne, arthralgia, plus features of hepatitis. So this is likely to be autoimmune hepatitis, okay? Autoimmune. If somebody is taking poorly ingested grains, poorly stored grains, you can think of aflatoxin. If somebody is living in riverine areas with history of, coming down with features of hepatitis, we think of schistosomiasis, okay? Next slide. Schistosomiasis, you think of schistosomiasis, okay? Next slide, please. By the way, schistosomiasis, apart from liver, it causes bladder cancer more commonly than liver disease, but it's one of the parasites implicated as a cause of chronic liver disease. It has a characteristic pattern of affectation of the liver. It causes what gastroenterologists call, it produces a pathology in the liver called what they call pipe stem fibrosis. It's specific to schistosomiasis, okay? They call it pipe stem fibrosis. This is chronic liver disease. So what are the causes of this hepatitis? There are a lot of causes of this hepatitis. As we mentioned, we said, one, hepatitis B and C, they're the commonest. Alcohol is one of the common causes. Then other diseases, ingestion of aflatoxin. Aflatoxin injection, yes, is the cause. Alpha-1 antitrypsin deficiency, it can cause chronic liver disease. Apart from chronic liver disease, it also cause another disease. Who can tell us another disease caused by alpha-1 antitrypsin deficiency? Anybody, please?
Emphysema?
Yes, emphysema. So if they give you a scenario, somebody with both emphysema and chronic liver disease, what is the most likely cause? Alpha-1 is one of the only things that can cause both emphysema and chronic liver disease, okay? So fatty liver to some extent can lead to chronic liver disease. Some people can develop fatty liver and can lead to, you understand? So other diseases, again, systemic diseases, they can affect the liver. and they can progress to chronic liver disease. Traditional medications, okay, they are known to. Other drugs, but those drugs, they cause commonly acute liver disease. They don't cause commonly chronic liver disease. So who can tell us among the 50 drugs that causes liver disease, who can tell us maybe 5, 10, please?
NSAIDs?
NSAIDs do not commonly cause liver disease to that level, okay? There are better ones. Anybody, please? What happened to our screen? Anybody?
So what of paracetamol overdose?
Overdose of paracetamol, good. Paracetamol overdose. Yes, I agree with you. Anti-tuberculous drug. Are we together? What is the commonest side effect of rifampicin?
Hepatotoxicity.
Hepatotoxicity. What is the commonest side effect of isoniazid? Hepatotoxicity. What is the commonest side effect of pyrazinamide? Hepatotoxicity. Apart from their specific hepatotoxicity, all of them. Anticonvulsant like carbamazepine, phenytoin, they can cause liver disease. Methotrexate, some chemotherapeutic agents like methotrexate, they are known to cause liver disease. Yeah. So even nevirapine to some extent can cause, fibrinogen can cause liver disease, okay? But majority of the drug, they cause acute form of liver disease, not chronic liver disease. So what are the features of this chronic liver disease? One, there are peripheral stigmata of chronic liver disease. Okay. One, weight loss, jaundice, ascites, sparse axillary hair, testicular atrophy in men, change in pattern of hair distribution, palmar erythema, leukonychia. Okay, next slide, please. So these are the causes. We've mentioned some of them. So presentation, abdominal swelling, yellowish discoloration of the eye, pruritus, amenorrhea, abdominal hair distribution, hyperpigmentation. Okay, next slide. What are differentials? Because chronic liver disease come with body swelling. So differential could be chronic liver disease, chronic kidney disease, chronic congestive cardiac failure, abdominal PV nephrotic syndrome. Okay, next slide. What are the complications? The complication of the chronic liver disease is because of the function of the liver. So synthetic function. We know that liver synthesizes proteins, okay, and other things, substances. So synthetic function, if this synthetic function is impaired, ascites and other symptoms will develop. Portal hypertension, hepatorenal syndrome, hepatic encephalopathy, hepatocellular carcinoma. These are some of the complications of chronic liver disease. All right, we'll see one of them now. Take one after the other. Next slide. So if you examine a patient with chronic liver, what are the things that you see? So sometimes there are general symptoms. There are symptoms depend on the cause of hepatitis. Like alcohol. If they tell you what are the stigmata of chronic liver that suggest alcohol as a cause, parotid swelling, Dupuytren's contraction, peripheral neuropathy, cerebellar signs, hepatomegaly. You understand? They could suggest, the two commonest that suggest liver disease are parotid swelling and Dupuytren's contraction. Other symptoms mentioned there could be seen in other causes, but the two most common for alcohol, parotid swelling and Dupuytren's contraction. If it is due to Wilson disease, they could have Keisha-Fleischer ring, okay? What they call sunflower cataract. In addition, they could have cerebellar signs, okay? Okay, so for picture test, you can have a picture of somebody with Keisha-Fleischer ring. It suggests of Wilson disease. Hepatitis C, we said any intravenous drug use, scarification mark, tattoos, we think of hepatitis C, okay? Next slide. So hepatic encephalopathy present with drowsiness, presence of asterixis, exaggerated deep tendon reflex, altered sleep pattern. Somebody will be sleeping more in the morning as against at night. Then patient may have coagulative problem, because we know that those coagulation factors, they are activated in the liver. You understand? Vitamin K dependent factors, they have one way of, and again, the liver produces those coagulation factors. If the liver is impaired, it won't produce fibrinogen, what have you, prothrombin, and what have you. Okay? Low albumin, again, ascites, leukonychia, edema, portal hypertension, ascites, upper GI bleeding, caput medusa, rectal bleeding. Note, gynecomastia, testicular atrophy, female pattern of hair due to what they call aromatization of the androgens. In the liver disease, those androgens are aromatized, and that will subsequently lead to presence of these features. Okay, so features of is due to features of impaired function of the liver. Could be synthetic, could be other functions. Okay, yeah. So next slide. So what are the investigations we like to do? In acute setting of the liver disease, liver function tests may be impaired, but in chronic liver disease, it may not be impaired. In chronic, if there is an acute insult, yes, it can be impaired, but just chronic like that, the liver enzyme may be relatively normal. So you can see, but albumin usually is low, bilirubin could be normal or high. They could have ALT, AST, but among them, ALT is the most important marker of liver disease, because AST can be raised in some other disease. So ALT, you pay more attention to ALT. And if you have ALT over AST ratio more than 2, you think of alcoholic liver disease, what they call Drittis ratio. Okay? They can have prolonged prothrombin time. Alkaline phosphatase are high if there is obstruction, cirrhosis. You can do abdominoplasty scan to see the architecture of the liver. The liver may be enlarged, enlargement of the spleen. The liver will maybe shrunken in chronic liver disease, in some form of chronic liver disease. Okay? Yes. Presence of ascites could be noted. Next slide. For some reason, sometimes you need to do liver biopsy if you could not find the cause. So it will tell you whether there is cirrhosis to cirrhotic change. So for you to do liver biopsy, your patient must fulfill the criteria which are mentioned above. Patient must give a consent, must cooperate. PT must not be less than 4. Platelet must be greater than 100 times 10 to the power 6. You have to exclude bile duct obstruction, advanced COPD. You can also decide to do ERCP, especially if there are obstructive jaundice. You can do ECR. You can take acetic fluid for analysis, which will tell you whether it's an exudative or transudative. Okay, next slide. So you can do investigation to determine the cause. We said hepatitis B, C, they are the commonest. So you can order for hepatitis B serology, hepatitis C. You can order for serum ferritin if you think of hemochromatosis. You can do other autoantibodies. In case of autoimmune hepatitis, you can do ANA, anti-nuclear antibody, you can do anti-mitochondrial antibody, you can do anti-smooth muscle antibody. You can check for serum ceruloplasmin in case of Wilson disease, alpha-1 antitrypsin deficiency. You can also check for alpha-1 feature protein in the case of primary liver cell carcinoma. Okay. So do we know any other condition where alpha feature protein is increased? I will give 10,000 naira. Okay, let's go. They don't want to eat this 10,000. Hello? They don't want to take this. Neural tube defect. Okay, I agree with you. But you have to be specific. Teratomas, okay? In teratoma, specifically. Okay? So, investigation to determine the extent of the disease. You can do PCV. In case of chronic liver disease, in some cases, don't be surprised to see the PCV is very high, polycythemia. Who knows why? What's the reason why a patient with chronic liver disease may have polycythemia? So let me give myself answer. Because liver cell, like if it is liver cell carcinoma, primary liver cell carcinoma, is an erythropoietin secreting tumor. There are other 7 erythropoietin secreting tumor in the body. 1, primary liver cell carcinoma, yes. 2, lung carcinoma is also erythropoietin secretion tumor. These are MCQ. 3, renal cell carcinoma. 4, hemangioblastoma. Hemangioblastoma, as in, especially in a disease called von Hippel-Lindau. Okay. The least among them is uterine fibroid. Uterine fibroid, again, is known to have erythropoietin secreting activity. So in this kind of patients, apart from, because they are chronic illness, patient can come down with anemia. On the other hand, they can come down with polycythemia because the tumor produces erythropoietin. But number one is primary liver cell carcinoma. And we said number 2 is lung carcinoma, especially small cell lung carcinoma. Number 3, renal cell carcinoma. Number 4, hemangioblastoma. There are a lot of tumors, like 3 more, that secrete erythropoietin. I can't remember the other one, but at least we're able to mention 4. Then the last one is uterine fibroid. So WBC may be low, may be high. Clotting profile could be ranged. Random blood sugar, fasting blood sugar may be low. So why do a patient with liver disease come down with? Okay, maybe an assignment, please. They could have the range UECR. We said they can develop hepatorenal syndrome. Yeah. Next slide. Treatment, nutrition is very important. Avoid excessive protein diet if you live in Western world, but in Nigeria, where our protein intake is not optimal, it's not a very good advice because we don't take even an optimal level of protein. We avoid NSAIDs, sedatives, because they can cause hepatic encephalopathy, alcohol. If there are pruritus, we give cholestyramine, which chelates bilirubin. Next slide. If they have bleeding, we can give them vitamin K. We can give platelet concentrate, fresh frozen plasma. If they develop infection, especially in spontaneous bacteria, we give them cefuroxime and metronidazole if possible. Before, we used to give aminoglycoside, neomycin, but recently it's known to have some effect. It's better to use cefuroxime or metronidazole. If they have ascites, we follow the protocol of management of ascites: bed rest, fluid restriction, no salt diet. We give them diuretics with spironolactone. So who can tell me in which ratio can we give furosemide and spironolactone in a patient with chronic liver disease? Which one should we give high and at which dose, and which one we should give less and at which dose? What's the ratio? Okay, before they tell me, then if patient fail all this treatment, we give paracentesis with sulfur-albumin. And again, if we remove 1 liter of acetic fluid, how many grams of albumin do we put? So for each 1 liter of ascites, if we are doing paracentesis, we have to infuse 6 to 8 grams of albumin. If you did not do that, you just remove the fluid, it will reaccumulate within 48-72 hours. But if you want the patient to get better from ascites, to stay longer without the accumulation, you have to give sulfur albumin. And again, for each 1 liter of acetic fluid you remove, you have to infuse 6 to 8 grams of albumin. So back to my question, the ratio of spironolactone to furosemide. We usually give high dose of spironolactone. We give ratio 2.5. If we give 100 milligram of spironolactone, we give 40 milligram of furosemide. So the ratio is 2.5 or minimum 2:1. But the actual ratio is 2.5:1. If we give 200 milligram of spironolactone, that means we have to give 80 milligram of furosemide. But the common dose we give is 100 milligram of spironolactone with 40 milligram of furosemide. Next slide, please. If they develop hypoglycemia, I ask you to go and read what are the reasons why patients with chronic liver disease come down with hypoglycemia. There are 2, 3, 4, or 5 reasons. If they develop hepatic encephalopathy, it's difficult to manage. You raise the head of the bed to 20 to 30 degrees, so you can give them mannitol or acetazolamide. You also give them lactulose just to prevent constipation, because we know constipation is one of the risk factors for hepatic encephalopathy. Sometimes you have to give them albumin or hemodialysis if they develop hepatorenal syndrome. Next slide. So specific treatment, if the cause is due to viral hepatitis, we said we can use interferon, lamivudine, ribavirin. We can also use, don't forget, adefovir. We can use entecavir and tenofovir. In fact, tenofovir is one of the commonest drugs that we use for hepatitis B. If it is hepatitis C, we can use soposbuvir, ledipasvir, boceprevir. There are many virs, depend on whether you use NS5 or NS4. And again, in some countries, they do biopsy. They do some other tests that detect which of the drug will be most suitable for that patient. And if you use it carefully, the cure rate is almost 95 to 100%. If they develop autoimmune hepatitis, if it is due to that, we give them azathioprine prednisolone. Next slide. If it is due to drug-induced liver, I mentioned some of the drugs that induce liver disease, we withdraw the drug. If it's due to Wilson disease, we give them penicillamine. All those ones, they are chelators of particular, okay, for penicillamine, they are chelators of copper. For the desferoxamine, they are for iron. In some cases, you need to do liver transplant for the patient to get cured. However, in Nigeria, there are no or few cases of liver transplants. In Africa as a whole, there are no more than 50 transplants. 40 of them was done in Egypt, to my knowledge, before. I don't know now. There are no more than 50 liver transplants that were carried out successfully in Africa. And staggering 40 of them were done in Egypt. None or few or none in Nigeria and other countries. So there's still a lot to do in terms of liver transplantation in Africa. Okay, next slide. Next slide, please. Okay, before we can't conclude without mentioning the precipitant of hepatic encephalopathy, please. Do you have any slides for that? Yeah, this is a very important slide, please. For your MCQs, for your knowledge, for any patient, for any one of you managing patient with hepatic, you have to be conscious of addressing this. For constipation, we used to give them lactulose, 15 or 20 mils TDS, to achieve at least 2 to 3 bowel motion in a day. But if it causes diarrhea, they should stop. You understand? High protein diet is not good in Nigeria to advise patients to reduce high protein, but excessive protein may cause, if they have GI bleeding again, that's why we give them prophylactic PPIs for any patient with chronic liver disease, so that they will not develop GI bleeding. And because GI bleeding may tilt them to hepatic encephalopathy, which is difficult to manage, which has poor prognosis, okay? Infection, we have to prevent infection. If they develop infection, we give them cefuroxime and metronidazole, as we said, as against neomycin that we were given before. We don't give them other drugs like opiates, even if they convulse, don't give them diazepam, please. Give them paraldehyde. Don't give them diazepam because it precipitates hepatic encephalopathy. You have to tell the nurse, please, even after I leave, if the patient convulses, don't give them. Because one of the common problems is when patient convulses in the ward before the doctor comes, nurses give diazepam. But these are the kind of patient that you tell them, nurse, please don't give this patient, even if he convulses. Okay? Because if they have hepatic encephalopathy, they can convulse. If they don't have, they can convulse from other sources. But if they have background liver disease, don't give them. Give them paraldehyde instead. Excessive diuretic therapy, yes, they can have hypotension, they can have hyponatremia and other things that may lead them to hepatic encephalopathy. Renal failure, if they develop renal failure, yes, also a risk factor for hepatic encephalopathy, okay? Thank you very much for listening. Thank you for being part of this lecture. Thank you for contributing. If you have any question, clarification, comment, you are free to ask. If you don't have, I'll ask one. I wanted to ask three, but I'll ask only one. If you ask one, so I will not ask my own question. Hello? No? Am I being heard? Hello?
Yes, sir, we can hear you, sir.
Any question? Oh, I should ask my own. Okay. I should ask my own. I asked, why do they have hypoglycemia, please? Oh, I should give you as an assignment to go and read. Hello?
Sir, is it due to decrease in glycogen storage?
Okay. Glycogen. They don't have excess storage, cool? There are other reasons. One of the reasons is insulin. This is one of the reasons. Yes, they may not have sufficient storage. Insulin is one of the site of metabolism of insulin is in the liver. So if the liver is diseased, the normal insulin produced by the body will not be broken down. It will remain, if insulin is going to stay for 6 hours, ideally in a normal setting, the liver then break it down. So the liver is diseased now. It won't break that insulin. The insulin will continue to last for more than 12, 24 hours. And we know what insulin does. It mobilizes glucose into the cell, depriving the plasma, you understand? So that's why all this glucose will mobilize into the inside the cells, leaving behind the blood deficient of glucose. So that's one of the reasons. Yes, glycogen storage, and there are other few or more reasons, okay? Please read about that. Thank you very much. Thank you very much. We meet. Is it tomorrow or next tomorrow?
Tomorrow, sir.
All right. Thank you very much. I wish you best. I hope you guys are reading very well for your exams.
We are trying, sir.
All right. Please do that, please. We wish you best. We have high hope on you guys. It's going to be nice in Kano, inshallah.
Okay. Thank you, sir.
Yes. Thank you. Thank you. Thank you. We meet tomorrow. Thank you.